Greetings, Earthlings, and welcome back to Ob-Gyn Education 23. This is the second video to go onto the channel, and today we're going to be talking about vaginal lacerations and their repair. My college speech communications instructor said that we should always tell our audience what we're going to tell them, and then tell them what you told them. So to give a bit of an overview for today, we'll start off with the PowerPoint presentation that is a bit of an overview of vaginal laceration. We will spend some time talking about suture selection. We'll obviously spend a bit of time looking at vulvar and vaginal anatomy, specifically as it pertains to vaginal laceration and repair. We'll talk about specifically the different classifications of vaginal laceration and how to approach those repairs. Then we'll transition to some videos that I made using a chicken model, where we will look at an in-depth repair of a second-degree laceration. We have another video for a fourth-degree laceration, which would obviously include repair of the external anal sphincter as well. So we will indirectly cover third-degree laceration repair as part of that video. We then have two more videos that we'll wrap up with, one looking at an interrupted suture approach to deep vaginal laceration, so repairing the vaginal floor deep to the mucosa. And then the final video is going to look at a similar but different approach to a deep vaginal repair, as well as a couple of approaches to perineal body laceration repair, including a horizontal and vertical approach. So, having said that, let's get right into it. So when it comes to suture selection, we're going to be, and this is a bit of an overview, but we're going to be talking about specifically absorbable suture that is either synthetic or naturally occurring. The naturally occurring we can talk about first, which is catgut, so either plain or chromic gut. It's quite rare to see this used. Currently, most people have preferentially been using Vicryl, and some folks using monocryl as a monofilament. The non-absorbables as a category would not be applicable for vaginal laceration repair. What I tend to do, I'm a Vicryl kind of guy. I tend to use a 2O Vicryl for deeper aspects of the repair and closure of the external anal sphincter, and a 3O for vaginal mucosa, perineal body, the kind of typical second-degree repair. Wait, abdominal wall? Why are we talking about that? It's always a good idea to talk about abdominal wall anatomy. A review of that never hurts. So let's talk about the layers we go through. Skin, subcutaneous tissue here, and remember, camps on scarpas. We've got our fascia here, rectus muscles, which we are separating in the midline here, and then peritoneum that we enter here. So to go through that in a sequential order, what we run into when we do, for instance, a fan and steel incision when we're doing a C-section. Skin incision, going down through the subcutaneous tissue again, camps on scarpas. We go through the fascia, separate the rectus muscle. Depending on the patient's body habitus, we'll have kind of a varying degree of preperitoneal fat here, and then get down to the perineum itself. All right, so throw that in. Just for a bit of a review, here we are onto vulvar anatomy. So the things that we're going to be most specifically interested in here are the vaginal floor and specifically the hymen as kind of a marker of our progression as we're repairing vaginal floor here. The posterior fourchette, which is really just the transition from this mucosal tissue of the vaginal floor to the keratinized skin of the perineal body. So perineum here, and then anus with what we're going to be talking about repairing, external anal sphincter. So another classic Netter slide. There's a lot going on here. So in order to simplify this, because what we really want to do is to look at the relationship of the vaginal canal and specifically the posterior floor to where we're going to be repairing that and then coming down perineal body. But this is a bit busy. So let's simplify this up a bit. What we're really looking at here, and this would be a sagittal view at the patient lithotomy position, we're looking here at vaginal canal, perineal body here, external anal sphincter, internal anal sphincter, and then into the rectum itself. So a couple of things to note here. Number one is that the further up the vaginal canal you go towards the cervix, so the more distal you get up the canal, the closer you're getting to rectum. So as we are repairing significantly long vaginal lacerations, so really reaching up here, we've got to be mindful of the depth of our sutures because we could be placing suture into the rectum. As we come down towards this transition from vaginal floor to perineal body, we've got quite a bit more depth that we're working with. So not only are we protected somewhat from placing suture inadvertently into the rectum, but we also have to be cognizant of the amount of tissue that we've got here that we'll need to be repairing to be able to get a good solid closure. We'll be talking in just a minute about some of the muscle and connective tissue here that we'll need to be repairing. So, the muscles of the vulva that we are really going to be focusing on, the bulbospongiosus, also called bulbocavernosus, and here with the superficial transverse perineus. You can see here this, I think of it as kind of a horseshoe-shaped muscular band for the bulbospongiosus, and the kind of horizontal approach here of the superficial transverse perineus. Obviously, if we have a laceration that's disrupting vaginal mucosa and then transitioning here down to perineal body, we're going to be separating bulbospongiosis, and because of the tone of that muscle, it tends to retract up. So we do have to be mindful of that as we're doing our crown stitch. What's a crown stitch, you may ask? We'll come to that shortly. The other thing here, external anal sphincter. So with the 3rd degree laceration that is disrupting the sphincter itself, we need to be mindful of getting a good bite of the muscle. So if we're looking here at sphincter and 3rd degree, so that sphincter is disrupted, again, it's going to retract inferiorly and laterally. So this is where we would typically use our Alice clamp to come in, grasp that tissue, and then put traction on it upward here so that we are absolutely certain that we're placing a suture through the sphincter itself. There are a couple of ways that you can repair the sphincter, and we'll come to that momentarily. Looking at blood supply, most of what we're going to be talking about are areas coming off the pudendal artery, and specifically with vaginal laceration here and then perineal body disruption, we're going to be looking at areas that come off the perineal artery as it relates to the proximal vagina, and then some of the inferior rectal artery vessels that are branching off if we're down into the scope of doing a 3rd or 4th degree repair. Vessels, for the most part, don't tend to cross the midline. There's obviously collateral flow here, but most of the time we're going to be looking for significant bleeding coming from kind of an individual branch of this on each side. When it comes to nerves, clearly, as we're doing vaginal laceration repair, and especially significant repair, we want to be mindful of adequate analgesia for the patient. If that's not an epidural regional anesthetic, then we absolutely want to be using a local I tend to use 1% lidocaine with epinephrine. Most of the innervation that we're going to be concerned about is coming off the pudendal nerve here. So branches of that are coming over to perineal body, up to the inferior aspect of the vaginal wall, and then depending on lacerations of labia minora or up to periclitoral, periurethral lacerations, we're going to be dealing with branches from the dorsal nerve of the clitoris. So this is a somewhat traditional way that vaginal lacerations are represented, and as a student and then resident, I was always somewhat dissatisfied with this because this two-dimensional view seems just very flat and hard to understand the anatomy. So they're talking about some specific landmarks here with vaginal mucosa here in its natural state, and then clearly the disruption starting here. So here's the apex of it up here. Disruption of the hymen. All right, that helps to give us a little bit of a clue of kind of the area that we're getting at. And then this transition to perineal body is a bit abstract. We really should be kind of showing the disrupted ends of the bulbospongiosis here, and then kind of that transverse perineal muscle coming in down here. This two-dimensional view I was just never satisfied with. That's what led me to do some of the schematics that I came up with. So before we get into those, let's talk about the classification of vaginal lacerations. A first degree is disruption of the vaginal mucosa and or perineal skin. These tend to be quite superficial. Here we've got a first degree tear, and it really is just vaginal skin or perineal body skin that's disrupted. This also can include small lacerations of the labia minora, and again, kind of the periurethral, periclitoral lacerations more superiorly. A second degree, which is what we're going to see most commonly and probably spend the most time talking about today, is disruption of the mucosa, but that goes deeper down into the vaginal muscularis, or disruption of the perineal body that goes down into the deeper connective tissue as well. Third degree, in general, is the idea of disruption of the external anal sphincter, but specifically broken down into three classifications. 3A, where there's less than 50% of the total diameter of the sphincter that's been disrupted. 3B, where it's greater than 50%, up to completely disrupted. And a 3C, where both the external and internal anal sphincters have been torn. Then a fourth degree, obviously, which we do have some examples of, and the repair, we'll spend a bit of time talking about that down here in the bottom right, where we've got disruption of the rectal mucosa. So looking here at rectal mucosa being divided, here's external anal sphincter, and their representation here of transverse perineal musculature and bulbospongiosis up here. So a little bit of a better drawing for being two-dimensional that shows vaginal floor disruption. You can see where it comes through the disrupted hymen here, and then transitions into this disruption down the perineal body, including here the sphincter for the third degree, rectal mucosa for the fourth degree. Another picture here, this one's a bit blurry unfortunately, but again, just a bit of a representation of vaginal floor transitioning to perineal body. Here we've got bulbocavernosus or bulbospongiosis muscle that's been divided. So you can imagine with the crown stitch, we're going to have to kind of get up into that muscle, and then here the same to really get a good bite of that that's going to bring that together and bulk up the perineal body, and then the superficial transverse perineal muscle here just inferior to that. So second degree, because we go through vaginal mucosa, perineal skin, and then into the deeper musculature. Third degree here with disruption of the sphincter. This looks to be a 3B. I'd say that's more than 50%, but maybe not totally disrupted here. You can see that little bit of white glistening here they're representing as the capsule that surrounds the sphincter. And then here the fourth degree, where you've got rectal mucosa, this pink layer here that's been disrupted, the internal anal sphincter here. So this would be a 3C, except that it's actually a fourth because we've got rectal mucosa as well. So representation here of the external sphincter, the internal sphincter kind of lying further up, and then again we're back up into bulbocavernosus there. So let's talk about the kind of logical progression of these stages of closure. Now, there are many different ways to do this, and you will see different attendings and midwives do closures that are anything from a single suture, which is what I tend to do unless interrupteds are needed for deeper areas or reapproximation of the sphincter or rectal mucosa. However, you can do this using 2 or 3 separate sutures for vaginal floor and perineal body, or even a 3rd suture for perineal skin. But the general idea is that the first thing we're going to do is repair the vaginal floor. And so that's what they're representing here. They're showing this as just a running suture. I tend to do this as running interlocking for hemostasis, because with that increased blood flow during pregnancy, there can be significant bleeding from vaginal mucosa. One of the things we want to do is to get down kind of a full depth of the disruption of that kind of paravaginal space. But that's our first step. So vaginal floor. The second step here is closure of the perineal body. So they're representing that here as these looks to be interrupted sutures that they're tying off, and then a 3rd stage of closing perineal skin. So here they're kind of mysteriously using a vertical mattress suture on the skin, which I admit I have not seen done before. But in general, these are going to be our 3 steps. We want to close the vaginal floor, transition to closing the deep perineal body, and then close the perineal skin. I like to add a couple more specific steps into that. So not only are we starting off with our first step of closing vaginal floor, but then we need to do some sort of a transition where we switch from the vaginal floor closure to the perineal body. So that's usually going in with your needle once you've closed vaginal mucosa. Again, here they're showing this just with a running suture. I do that as a running interlocking. But anyway, going in vaginal mucosa and then kind of popping out down here in the perineal body. That's our transition stitch. The next thing that I do is, again, we've got our bulbospongiosis that's coming up here on each side. This is showing somewhat of medial lateral laceration or episiotomy, but this musculature is going to be disrupted right down here. So whether we have a midline defect or a more lateral or medial defect, we need to bring this muscle back together. So the crown stitch is to reapproximate that bulbocavernosus, coming up and getting a good bite of it here, coming up and getting a good bite of it here to reapproximate that and bulk up the perineal body. The transverse perineal muscle down here may be disrupted with a medial or more lateral laceration, but certainly with the midline laceration will be disrupted. But I close that just as part of our kind of, again, second big step, the perineal body closure. And then closing the perineal skin. So again, vaginal floor, transitioning down to the perineum, doing the crown stitch to reapproximate our bulbocavernosus, closing the perineal body, closing the perineal skin, and that's it. So let's see what that looks like in a little bit more of a 3-dimensional model. So this is the schematic that I came up with a couple of years ago, and what this is showing is vaginal opening here, cervix here. We've got perineum here, external anal sphincter, and then anus here, and rectal mucosa specifically being shown. Our pink curved horseshoe here, the bulbocavernosus. So what we're going to do is we're going to break this down into 3 areas again. The vaginal floor disruption here, our perineal body disruption here, and when it comes to 3rd degree, we're going to be looking at disruption of the sphincter itself. So again, usually kind of at this 12 o'clock position and the repair of that. And when it comes to our 4th degree, we're going to be looking at disruption of the rectal mucosa. All right, so here we've got vaginal mucosal disruption represented in red, our perineal skin disruption represented in purple, and the yellow line here is just representing the depth of this disruption, which obviously can be anything from a relatively shallow defect right under the vaginal floor, transitioning down to perineal body, so not a lot, to repair there. Or you can have a relatively deep defect where it really drops down and is a big, big opening all the way from the apex of the vaginal disruption down to the perineal body. What I've represented here with the yellow is something kind of in the middle. Relatively shallow right at the apex, but then does get a little bit of depth to it here throughout the vaginal floor as it transitions to perineum. Here we've got a representation of external anal sphincter that's intact. So looking at this from a direct sagittal viewpoint, we've got kind of two planes that we're working with. The vaginal floor here in red, the perineal body in purple, and again this yellow representing kind of the depth of the defect. And again down here, anus, and then external and internal anal sphincter. So this is the representation that we're going to be working with as we're both schematically and then with our videos doing these repairs. So, second degree closure. This is closure of the vaginal mucosa and underlying muscle. We begin distal to the apex, so we want to go up above the apex of the disruption in vaginal mucosa. We do that for hemostatic reasons because we want all areas of disrupted tissue to be contained within a compression area of our running interlocking suture. I tend to do running interlocking all the way down to the introitus when I do my transition. There are some studies that look at, so here if we're kind of representing the hymenal ring, stopping the interlocking part of it when you get to the hymen. I've read kind of theoretical concerns of scar tissue, possible dyspareunia, but not anything conclusive. Anecdotally, I think that the degree of hemostasis that you achieve with the locking suture is of benefit. So we've got this represented here with our running interlocking suture closing vaginal floor. So if you have, as we talked about, this very deep defect, I tend to close those with interrupted sutures, and I tend to use a 2-ovicral. For my typical second degree closure, I tend to use a 3-ovicral, but if I'm doing something that's a little bit more of a higher tension area, closing the sphincter, for instance, with a 3rd degree, or closing deep aspects of the perineal body or that perivaginal tissue, I like the little bit of a bigger suture for that. My goal is to always kind of get back to a shallow 2nd degree closure. However, as we talked about before, we want to be mindful, especially the further up we are towards the apex here, we want to be mindful of how close we're getting to the rectum. Whenever you're doing a vaginal repair, you absolutely should do a rectal exam at the end of it. It doesn't matter if it's relatively superficial repair. Certainly, the deeper the repair, if you're doing a 3rd degree or 4th degree, you're absolutely obligated to do a rectal exam. I typically do one with any repair because if you had placed a suture rectally, that's the time to find it and deal with it. So again, representing here this closure of the deep area, and then as we can see over here, once we've gotten these interrupted sutures placed, we've now gotten back to a more shallow defect represented by the thicker yellow line here. So our transition stitch. We've got our vaginal floor closed with our running interlocking suture. And again, transition is just going from the vaginal floor closure, getting ready for perineal body. And so it's just poking into vaginal mucosa here, right near introitus, and then popping out really just anywhere in the perineal body. And I'm trying to represent that kind of from the surgeon's point of view here, popping in vaginal mucosa, pop out there in the perineal body. So that's our transition stitch. So as far as our crown, again, we've got represented here our bulbocavernosus or bulbospongiosus muscle. And again, this horseshoe shaped that comes down has been disrupted in the midline. Here we've got our transverse perineal. This muscle does retract a little bit because of its resting tone. So once we've closed vaginal floor, we've done our transition. So now we've got our suturing needle kind of down in the perineal area. what I do is I tend to go up with a fairly big bite into the belly of this muscle. As you're there and give just a gentle tug down on it, you should see all the way up the labia majora a little bit of disruption or kind of traction inferiorly. That lets you know you've got a good bite of that muscle. So really going up and getting a good bite there. And this is relatively superficial under the skin. You're not heading real deep kind of up parallel to the vagina, but you're also not staying directly under the skin. It's, if anything, splitting the difference. When I pop out here, I tend to come up this way to get that on the patient's right side, and then that forms a nice circle of suture that brings that area together. So we've closed vaginal mucosa, we've done our transition, we've done our crown stitch to get our bulbocavernosus back together, which I've not represented here very well. So now it's time to close the perineal body. And there are kind of three ways that you can do this. One is, if you have a very deep defect, you can do interrupted sutures there. And again, I tend to do interrupteds of 2 ovicral. Again, if this is a very deep defect, just doing the superficial closure is not going to cut it. We don't want to leave a potential space there, dead space. So you would need to get in and close off that deeper area. But we'll come back to that. So as far as just a kind of normal depth, but on the deeper side, I tend to do a more vertical type closure, but this is running. But I would go in here, and I like to come out right above where the tissue meets up at the base of the defect, and then pop in here and come out, transition down, and do the same. So this is a vertical type. We're placing our needle. So if this is kind of the line of the opening of the skin, we're placing our needle perpendicular to that, if that makes sense. And that's in contrast to a more shallow defect in the perineal body where I do more horizontal type closure. So with the horizontal type closure, if we've got the direction of the defect in the skin, we're placing the needle parallel to that. So popping in a bit under the skin edge. Again, you gauge the depth of that based on how deep the defect is overall. We don't want to be too close to the skin because then it'll deform it or pucker it up. But going in, traveling down, and then coming out. This is somewhat similar to what we would do for a subcutaneous closure with a laparotomy. We'll talk about this in the video a bit, but when I do these sutures, I do backtrack just a little bit. When we do subcuticular closures, we're used to kind of coming straight across to do our next bite through the skin layer, straight across. If you backtrack, you tend to bunch up the skin. You don't get as nice of a cosmetic result. But here, where we're really kind of bulking up and closing that bigger defect, I do backtrack a small amount. So, again, closing the perineal skin. We've got vaginal floor closed. We did our transition. We did our crown, which again I've not really represented here. The bulbocavernosus should be back together. We've closed perineal body, and now all we have left is perineal skin. So what I typically do for that is when I'm closing perineal body, I pop out right at the apex here, and then it's just a subcuticular type closure just under skin edge, back up to the top. And then to finish this off, I usually will do a through and through, right through vaginal mucosa, just inside the introitus. Again, we'll have some examples of that with the videos. So third degree. So third degree laceration, as we talked about, is a disruption of part or all of the external anal sphincter, or including the internal sphincter if we have a 3C. I typically repair the sphincter itself with interrupted sutures of 2 ovicral. This is talked about as a Pisa approach. So 4 sutures starting with a posterior, then inferior, superior, and anterior to really bring the muscle back together. I then close the deep perineal body with interrupted 2Os because invariably if you've got at least 3B to 3C laceration, you're going to have a significant disruption of this deeper aspect of the perineal body here going down towards the sphincter. The goal that I have, again, is to get back to a shallow second degree, because that's what I think of as standard closure. So closing the sphincter itself, some interrupteds for the deep perineal body, and then back up to the apex to start with our typical second degree closure. Let's talk about another variation compared to this kind of end-to-end closure here, where we're bringing the kind of flat discs of the sphincter back together, and as you may imagine, it doesn't look quite like this schematic in real life. Another option is to kind of knuckle under the sphincter like this. Oh, I did that incorrectly. Let's try that again. There we go. So to actually tuck these edges and then suture this together here, so that you've really bulked up this area of disruption with a almost kind of 3 to 4 layer closure by getting all of this area closed. So an alternative, I tend not to do that. I like the kind of end-to-end approach, and I don't think the literature supports that one is more efficacious compared to the other. But let's talk a little bit more about this end-to-end approach. Ideally, it talks about this kind of 4-step process with the PISA, posterior here in red, inferior in green, superior in yellow, anterior in blue. The reason for that progression is that if you started here anteriorly, you're going to close off the sphincter and not really be able to get back to the deeper areas of it and the inferior areas. So it's starting here with our posterior, and then going down to our inferior, superior, and anterior. I find that it's just really difficult to get 4 interrupted sutures in such a small space and with such a relatively small cross-sectional area of muscle. So I tend to do the crooked Mercedes symbol, which is a kind of 3-step approach, so 3 interrupted sutures. I do start off with that posterior here in red, but then I do a little bit of a kind of superior anterior, and then kind of an inferior anterior like that. And again, this makes up kind of my crooked Mercedes. So 3 areas instead of 4. If you can get 4 in there, that's fine. That's a lot of suture material that's passing through the sphincter itself. All right, so let's talk 4th degree laceration. Back to our schematic here. We've got our red vaginal mucosa disrupted, our purple perineal body, our yellow line here representing overall depth, and then here we're adding in this green line, disruption of rectal mucosa. So we've clearly got the sphincter that's divided here and disruption of the anus and rectal mucosa. So looking at it from kind of the surgeon's point of view here, we've got vaginal floor defect that transitions to perineal body, but goes all the way down through sphincter to the anus, and then rectal mucosa here in green. So what we're going to do is we're going to start off here closing rectal mucosa. We may put in some interrupteds to close this deep space. We'll do our 3 or 4 bites to close the sphincter, maybe some more deep interrupteds for the vaginal floor perineal body, and then again the goal is to get back to a second degree. So when we close rectal mucosa, sphincter, deep spaces, then we're left with again our second degree vaginal floor perineal body, and of course our poor bulbal cavernosus here that needs to be reapproximated. So 4th degree laceration, disruption of the rectal mucosa. I tend to close that with a forovicral in a somewhat subcuticular fashion. We'll demonstrate that shortly. The goal here is to not put any suture material into the rectum itself. So we're actually going to be closing the tissue just immediately above the rectal mucosa, again in a somewhat subcuticular fashion, or horizontal fashion if you would like, to close that area without breaching the mucosa itself. Begin distal to the apex, take small bites. You can tie at the anal verge or begin to transition superiorly, kind of up through the anal skin to perineal skin, we have a representation of that to show you what I'm talking about. Again, most of the time, if we've got a 4th degree, we've got some pretty deep tissue here that needs to be repaired. So we're going to repair that perirectal space in the deep perineal body, because again, we've got a lot of depth throughout here to repair. And again, the goal is, let's get back to a somewhat typical 2nd degree laceration, and then we really know what to do from there. So what we do is we start with the mucosa. Again, I use a forovical for this. I didn't see in the literature anything that specifically addressed using a monocryl. That would possibly be a fairly good choice for a suture. I don't think I would use chromic. That inflammatory aspect we would like to avoid, I think. Anyway, so we're using our foro. We're doing this in a running subcuticular fashion, as we said, without breaching the mucosa. We're going to start up here distal to the apex with just a through and through anchoring, like we would with kind of any subcuticular, and then taking these horizontal bites through this yellow line here is just representing this perirectal tissue, which is connective tissue, and we're going through that just above the green rectal mucosa. And again, I'm representing this with just a little bit of a backtrack because we really want to make sure this is a watertight, for lack of a better word, closure. So we don't really want any open spaces or gaps here. And then once we get down to the end of the closure of the rectal mucosa, we can tie that or kind of transition up a little bit. Again, we'll come back to that. Here's a little bit of a just off of oblique sagittal view, or here a true sagittal view, and this is showing the planes that we're talking about. So the red, our vaginal floor, this purple-blue perineal body, green is rectal mucosa, the yellow, this perirectal tissue, pink here is our external anal sphincter, internal sphincter would be kind of in here, and then here the anus itself. So the area we're talking about placing the suture, here's our through and through to anchor it, and then here's the direction of travel with our suture. You can see it's that horizontal fashion where we're going through the perirectal tissue just above the mucosa, so not coming down into rectum itself here into the lumen, but staying just above mucosa. As far as how far you carry that repair, what some folks do is they'll start here with their anchoring suture, travel down just above the mucosa, closing it, and then when they get to the end of the mucosa, they'll tie here that yellow dot. What I find with that is then, once I've repaired the sphincter, put in some deep closure here of the perineal body, come back to our 2nd degree, so vagina, transition, crown, perineal body. As I'm coming down perineal body, we really have to go deep. And oftentimes there's a little bit of a corner that you have to turn this way to get all the way down to really kind of meet up with where you've tied this foro that was your mucosal closure. That's a hard area to negotiate, I think. So what I typically do is this option over here. What I do when I'm closing just above the mucosa with my foro is that I'll bring it down and then do a bit of a subcuticular closure for the perineal body skin. Oftentimes I'll come down to this extent here, set that needle aside, do my sphincter repair, maybe put in some of my deep closures, then come back to this and travel up the perineal skin just a little bit and tie that off. Now, when I come back to my, what we've kind of turned into a 2nd degree closure, vaginal floor, transition, crown, perineal body, and I can pop out here at the apex to then begin my perineal skin closure. I don't have to come down and negotiate this corner. I don't have to get too close to rectal mucosa itself or rectum. It's just nice to be able to avoid that area, to have more of, if this is kind of surgeon's eyeball here, we've got a much easier time viewing this area than trying to kind of peek around the corner to make sure that we've got a nice contiguous closure. So it's perfectly fine to just come down and stop right when you get to the end of mucosa, where it transitions to the skin, the keratinized external skin. But like I said, I like to turn that corner a little bit and come up, so I make it quite a bit easier on myself once I'm closing perineal body. All right, so that is a lot to talk about. Let's put that to use. We've got a chicken model that I came up with that should help to demonstrate how we're going to go about these closures. This is the setup that I made. You can see here are bicolored chicken breast, which we're going to look at in a bit more detail. And special thanks to Dwayne and the folks in the Simulation Center for helping to get this all set up. So to represent a second-degree laceration, this is what we've got. The red stained tissue here is representing vaginal floor. You'd have to imagine vaginal opening kind of here. So here's our defect in vaginal floor. Green is perineal body. This yellow stained area here is supposed to be representing our bulbocavernosus that's been disrupted. And since this is a second degree, the sphincter and anus would be down here just off the picture. So what we're going to do is come up above the apex, do our running interlocking to close this, do our transition, we'll do our crown on each side to close that bulbocavernosus, close our perineal body, pop out at the apex, and come back up with the skin closure. Now, we also have a fourth degree laceration model here. So again, we've got red representing vaginal mucosa, green representing perineal body, and then here, this cut edge here and here represent the disrupted rectal mucosa. The red stained area here is representing external anal sphincter. And then kind of rest of anus itself would be here. This is a bit of a, as I called it, a Franken butt, as we've got a couple of chicken breasts that have been fashioned together to get to this stage. So again, rectal mucosa being divided here. We're going to come up just beyond the apex and then do our subcuticular, for lack of a better word, closure just above rectal mucosa. We'll do our 3 or 4 sutures through the sphincter to close that off. Obviously, we've got a pretty deep defect here, so we would do some interrupteds through this area, maybe even through the perivaginal tissue as well. And again, the goal is always get us back to a second degree, because that's kind of our straightforward floor, perineal body, perineal skin closure. All right, so let's look at some videos. Again, this is the chicken model that we put together.
All right, so we're going to
and we'll just sit back and watch this repair.
And this video will be narrated. We're going to be using a 3.0 Vicryl. This is a double suture, a GS24 tapered needle. And what we've got here is, again, red representing vaginal mucosa, green perineal body, perineal skin, and then the yellow here representing the bulbospongiosis or bulbocavernosus, whichever term you prefer. So the apex of the vaginal defect, vaginal mucosal defect, is here, and it's got some depth to it, but we're going to just do a running interlocking closure here. We'll do our transition, going in vaginal mucosa, popping out down here in the perineal body. Then we'll do our crown stitch to come here on the patient's left, and then on the right to get the closure of the bulbospongiosis, really reinforced perineal body. This is a little bit of depth here to the perineal body defect, so we'll do probably a bit more of a vertical or kind of oblique closure coming down there, pop out at the apex, and then back up with our subcuticular closure of the perineal skin. So let's go ahead and get started. We're going to come up above the apex of the vaginal mucosa defect. If that apex really goes up there and you're doing your spreading of labia to be able to visualize that and you can't quite see it, what I do is I just come up as far as I can safely see and suture. So, and this is of course a bit artificial as far as the tissue that we have with our chicken breast. This suture pulls through fairly easily, so we'll try to be a little bit gentle here. We're just going to do 3 throws with Vicryl. Obviously it would be 4. All right, so let's say that I've gone up kind of as far as I could see, but now what I can do is I can grab the suture and use it to pull down and use that traction to be able to see the true apex. So if there's a bit more of vaginal defect up here, which it looks like I got pretty close to the apex, we'll just create a little bit more defect there. So I can use the suture to pull down on that until I can see up to the true apex itself, come through. We'll lock this. And there we go. And then just continue to come down. And I'm going to take fairly good sized bites here. You can come out in the middle if you need to, depending on the depth of tissue that you're closing here. We always have to be mindful of how deep we're going because the rectum is just under the vaginal floor there. So running interlocking here for vaginal floor. Some people stop locking these sutures when they get to the hymenal ring. I tend to continue because we're of course doing the interlocking for hemostasis, and I haven't found that hemostasis dramatically improves just for being outside the hymenal ring. So we're going to come down here and do probably our final suture through vaginal mucosa itself. There we go. So we have a nice running interlocking. We've got good compression there. So now that we've closed vaginal mucosa, it's time to transition to closing perineal body. And what we're going to do for that is our transition stitch. So we're going to come up here and just go in vaginal mucosa and then pop out here in the midline through perineal body like that. So that's just to get our needle from this closure to this closure. Now, time for the crown stitch. So again, we've got our little yellow stains here representing the bulbocavernosus, bulbospongiosis. And what I do with this is really a fairly aggressive bite up and then curve that around a little bit exaggerated here. We want to get a good bite through that left side there. And then since we came out down here low, we're going to go in low and a big bite through that. Pop out here. So we get kind of a nice closure. You can see how that's going to pull the 2 parts of that split muscle together. All right, so now that we've got that, we can start to close perineal body. And again, this has some depth to it. So instead of doing a purely horizontal and then leaving all of this space uncovered, we would try to come in and do a little bit more of a vertical. But here, I'm just going to do kind of an oblique. So I'm going to go in and come out down here. So I'm not truly perpendicular with my needle to the skin edge, which would be a vertical closure. And I'm certainly not parallel, which would be horizontal, but I'm just a little bit oblique. And I'm going to back up a little bit here, do just a little bit of backtracking.
In one of the videos, I got the horizontal and vertical mixed up for closing the perineal body. So again, with a vertical type closure, obviously the needle is perpendicular to the line of closure of the perineal skin. For horizontal closure, more parallel to the needle being parallel to the perineal skin. So.
Because with this sort of large defect, we want to get some good closure there. And back to the side here. If you're doing these in a more vertical fashion, you can go across in one bite, but I like to come out, and you can see how I'm just doing a little bit of backtracking here to make sure I really get a good closure there. And I'll do probably one more on each side, and we'll be ready to pop out at the apex. All right, so we've got perineal body closed now, and what we're going to finish off with is closing perineal skin. So we're going to come down here and go in and pop out just right at the apex itself, not through skin. There we go. And then this is a subcuticular coming back up, so right under skin edge itself. And we'll pop out, and it tore through a little bit. My chicken's getting a little room temperature here. That's a little deep. And then sometimes I'll backhand these, sometimes forehand them. I do just backtrack the littlest bit. And try to avoid grabbing the needle tip itself. It'll dull it down, and it can break off if you bend it back and forth once or twice. I think just maybe one more small one on each side. There are a variety of ways to finish this off, but I'll show you how I do it. So maybe just a small little bite through there. And then that brings the skin edges back together. And then how I finish it off is to do a little through and through here, right at vaginal mucosa, and then tie that off, which we can do a quick little instrument tie just to get that finished. I'm just going to do 2 throws there since we're a little bit short. So there you go. Started up at the apex. We were a little bit short of it, so we used traction to pull it down and get up to just beyond the true apex, running, interlocking, closing vaginal mucosa. We did our transition stitch going in the mucosa and out in the perineal body. We did our crown stitch, getting the bulbocavernosus reapproximated, closed perineal body, popped out at the apex, and back up to the subcuticular to close the perineal skin.
All right, so a nice overview of a secondary closure. And again, the steps that we talked about: closing the vaginal floor, transition, crown stitch, perineal body, perineal skin. Let's look now at the 4th degree
All right,
closure.
let's talk 4th degree repairs. First off, let's do a little survey of what we have going on here. So again, red represents vaginal floor, vaginal mucosa. Green is perineal body. The yellow here is bulbospongiosis, bulbocavernosus. Perineal body here. The red dot here is external anal sphincter. And then here is our anus, which you can see has been disrupted. So this kind of light pink area here and here, that's representing rectal mucosa. So rectum is down here, mucosa has been breached, our 4th degree, sphincter has been disrupted, so that's our 3rd degree and then all of our second degree there. So let's talk about our approach. What we're going to do, I typically use a 4-0 vicryl for this. You come just above the apex of the rectal mucosa tear, throw a knot there, and then come down just above the mucosa. So you don't want to place any suture material in the rectum itself. Once you have that closed, I usually will do 1 or 2 interrupteds here to close this deep space, and then come to close the external sphincter. That's our PISA, posterior, inferior, superior, anterior. Once you get the sphincter reapproximated, again, I may do another interrupted along the perineal body, a couple of those just to close off this deep space, because these do tend to be a bit deeper, but not always. And then at that point, we will have closed mucosa of the rectum. We will have reapproximated the external anal sphincter. We will have done some deep closure of the perineal body. And so we'll be back to our second degree closure. So let's just see what that looks like. Here I have, just because of the kind of delicate nature of my now warm chicken breast, I have a small needle with a 3-0 vicryl. That's going to kind of substitute for our 4-0. This does tend to pull through the tissue a bit. Let's see if we can do a little bit of a zoom. On that area. All right, so, and this is something that's very good to have an assistant to be able to help you with. So again, the pink here kind of representing the border of rectal mucosa, the undyed tissue here being kind of within the rectum itself, and then the edge of mucosa right there, and same thing on that side. So we're gonna come just above that area here for our first bite. And again, this is a relatively poor approximation that already pulled out a little bit on that side, but let's see if we can get a little bit of another bite just to get this tied off. And we'll be, yeah, that's just pulling right through. All right, let's try again here. When the chicken first came out of the fridge, it was a little bit easier to work with just from its firmness. Yeah, so that's where that's pulled through a bit. Let's see if we can just do, and maybe just for illustration's sake, we'll just try to do a single, just kind of a 1-bite tie, kind of for an anchoring, because we really just need to be able to demonstrate how we go about this. All right. 4 throws for vicryl, of course, that's just 2, but all right, so we have our first bite that is just above mucosa. So again, the mucosa here is pink. So what you want to do is come along and do kind of a subcuticular that's just above mucosa. And here we may only get kind of 1 or 2 bites out of this. There's my needle coming through. So again, we don't want any suture material to be going into the rectum itself. So again, we would just be kind of skimming right above mucosa. I did a little bit of a backtrack there, and hopefully this will start to close that off. Yeah. Not too bad for our Franken butt. Backtrack just a little bit there. That was not a very big bite. We're just going to exaggerate this a little bit, just so that we can demonstrate. This is obviously a couple of chicken breasts that are sewn together. All right, so with that, you can see how we've closed the rectal mucosa, or More specifically, we have put our suture just above it. But now, if you did a rectal exam here, our little Franken butt, you would not be able to feel any suture material there. So one of the things that I talk about is when you get to the end of rectal mucosa, do you just tie this here, or do you start to transition up just a little bit of the outside skin? And I tend to do just one or two little bites, kind of turning the corner here and coming up the skin. Otherwise, if we tie this here, this gets buried a little bit kind of deeply here, so that when we're coming down perineal body, and then we are going to go to pop out at the apex to close perineal skin, we've got to come way down and even kind of turn the corner back to rectal mucosa. So instead of tying it right here, what I might do is come and do just one, maybe one bite on each side, kind of turning that corner to start to come superiorly. And yeah, this is going to be a little bit of an exaggeration here to start to close. To start to close just a little bit of that skin. So you can see there, all of that just is going to pull through. So let's say that we have decided to tie here. And so we're just going to go a quick little through and through here. And again, I would never instrument tie this in real life, but just to kind of get it done. All right, so if we've closed rectal mucosa, and now it's time to address the sphincter itself, which I would do in real life with a 2-ovicral, but again, because of the nature of this, we're just going to stick with this smaller needle. So 4 bites: posterior, inferior, superior, and anterior. What I find is that there generally isn't quite room enough for that, so I do 3. I tend to do this posterior, and then 1 kind of down here, 1 up here, so I get 3 to close that off. So we'll see if the suture will hold. This is going to be kind of our posterior. We actually are coming out kind of through the sphincter itself. And then we'll come over here and do kind of the same. And again, we'll instrument tie this, which we would not do in real life, but just to get some idea. So you can see how that's closing that deeper aspect of the sphincter itself. So let's say there's our first. And that's our posterior. So I would come down here, and we kind of come from the outside and come out sphincter itself. Trying to be very delicate with the tissue because these are pulling through fairly easily. And in sphincter and out kind of there. And again, we're just going to do 2 throws here to kind of simplify the process a little bit. All right, and then we come up and do kind of our 1 more superior. And again, we're coming out through the sphincter itself. and then in sphincter and out here. All right, so you can see that we've got our bites there that re-approximate the sphincter itself. What I would do then is getting another 2-0, but here we're just going to be using another 3-0 because of the small needle. You can see how deep of a defect we have in the perineal body. What I tend to do is to come in here and do a couple of deeper interrupteds to close this space. We're just going to do one here to kind of show that. And the reason for this is that it's just kind of too much depth to close with just our normal perineal body closure as we've done our transition crown and then we're headed down. So this just closes off some of that deep space. And again, we're just going to do 2 throws here for simplicity's sake. And you can do multiple interrupteds here. It's going to depend on how big the defect is, how deep it is. But once I do a couple of deep, I always come and right immediately above sphincter, I do another 1 or 2 interrupteds here because I really want to kind of bulk that area up. So I'm not going through sphincter itself here because we've already done that and re-approximated it. But I'll do a couple of interrupteds like that. So you can see that little bit of the red dye that we're using to represent the sphincter itself and how this is closing above that space. So once you've done some more of these interrupteds, you end up closing off the deep aspect of perineal body. We can just do another one here. And again, you've not only re-approximated the sphincter itself, but you've reinforced that area here just superior to it. So now we've gotten ourselves back to a fairly normal 2nd degree laceration. So we would come up here above the apex, close vaginal mucosa, do our transition stitch, do our crown here. So above apex, close vaginal mucosa, do our transition, do our crown to close the bulbous spongiosis here. Perineal body, you can see we still have plenty of depth there to close off. Pop out down here at this apex and then come back up and close skin itself.
All right, so I hope that's helpful to see the anatomical relationships that go into a 4th degree laceration. With that video, it's clearly not exactly how we would repair that. Obviously, 4 throws for Vicryl, not doing instrument ties. But my goal with that was just to show the approach to closure, the layers that we're evaluating, how we go about making suture selection and placement, and I think that's a good overview. Let's pop back to our PowerPoint for a minute, because we have another video where we're going to look at some of these deep repairs. So we had talked about, again, this yellow line here representing kind of a deep defect under vaginal floor and kind of behind perineal skin, so in the perineal body itself. We're going to look at some of these interrupted suture techniques. One of the other things that I have represented in the final video is going to be the idea of, let's say you had actually closed vaginal mucosa and you're getting ready to transition down to your perineal body closure, and then anus is here, say sphincter is intact. But when you're getting ready to close the perineal body, you notice that with your relatively superficial vaginal floor closure, this was actually a little bit of a deeper defect, and maybe your sutures for the vaginal floor closure only came down yay far. And so you've got this open space here that you're just not going to be able to get fully back and close off with your perineal body closure. So one of the things that I do when I inadvertently end up with a bit of a bigger defect there in the vaginal floor is to place one or two interrupted sutures in a kind of a parallel situation, parallel to the vaginal floor. So a couple of interrupteds thrown here, and again, obviously thrown kind of through the opening in the perineal body here, but that the needle is kind of flat, parallel under the vaginal floor. So that'll be included in the final video. So the video coming up, we'll talk about this deep vaginal closure with some interrupteds, and then we'll be back. So I'm just going to go ahead and narrate this video, and what we're looking at here is going to be a bit of a deeper vaginal defect. Again, going up beyond the apex for our closure. If this is really significantly deep and you feel that you're not able to get it with the closure that's including the vaginal mucosa, so basically one deep bite that's from mucosa down isn't going to get that full space, that's when you can do these deeper interrupted sutures. Again, I typically use a 2.0 and a little bit of a bigger needle, maybe a CT1, but because of the demonstration here, we're using a little bit of a smaller with that SH, just for illustrative purposes. So you can see that we're going in below the mucosa down into that kind of vaginal muscularis paravaginal tissue. And again, we would be doing 4 throws, of course, for Vicryl, but we're just abbreviating that here for simplicity's sake. The suture tended to pull out of the chicken as the meat had warmed up a bit. I usually come out in the midline. I don't like to try to go all the way across and then back up through the other side with one bite. I feel like I get much better, more purposeful placement of this second bite if I do come out in the middle and take them individually. I'll again comment on the fact that we need to be very cognizant of how deeply we're throwing these sutures, especially as we're up closer to the apex of this, because the rectum is in fairly close proximity to the vagina. After we do these sorts of sutures, it's best really to do a rectal exam, not even waiting until the end of the entire repair, but when I'm done with a certain stage, like these deep interrupted sutures, I would put on another glove, do a rectal exam, make sure that there's nothing that's in the rectum, and then proceed with the rest of the closure. So there we've got 3 interrupteds closing that deep vaginal space. Now we can go back to our, again, kind of standard second degree. You've heard me say it several times, and it's part of my mantra for these closures is get back to a relatively shallow second degree. And then I think from here on out we've just got a closure of this second degree. Again, the idea of being able to just go as far up the mucosa as you can see and go safely, making a little bit more of a defect up beyond the apex there, just to highlight that if we can't get all the way to the apex with our first bite, go as far up as you can go safely, and then once you tie that, you can use the suture as traction to pull down and be able to visualize the apex itself, and now we're going up above the apex. And I do lock this first more distal throw here just because I want all of the area of disrupted mucosa and muscularis to be included in a compressed area of the running interlocking aspect of the suture. And what I'm doing here is going down to just above the closure that I got with those 3 deep interrupteds. We don't want to leave a big gap between what we're closing with the deeper interrupted sutures and with this more superficial mucosal closure. We don't want to leave really any of that disrupted tissue that could be potentially bleeding. We don't want to leave any of that tissue outside of a compressed area within the 2 layers of this closure. All right, so we'll pop back to PowerPoint and examine our final aspect of closure. So, again, we're going to be looking at a deeper defect in the perineal body, as we just did with the previous video at that deeper defect in the vaginal floor here. Now, what if, regardless of how deep the defect is under the floor of the vagina, if we have a deep defect here of perineal body? Or, conversely, if we have a relatively shallow defect. So, for the deeper defect, you're going to take this vertical approach as we talked about, where in and then out at the bottom, just above the base of the defect. Again, we don't want to leave a big gap here because we want all of this area to be compressed within our suture line. And then a more shallow defect here where we do the more horizontal, so again, parallel with the needle to the direction of the opening in the skin.
All right, so let's say that we've got our vaginal floor closed here with our running interlocking, and we've gone relatively superficial through mucosa, and now we get to this point and we go to feel our integrity, and we find that we've actually got quite a gap under here. So we were a little bit too superficial. We've got kind of that little cave, that little defect that goes back under vaginal mucosa, and we don't really want to leave that. This would be time here for our transition stitch and then our crown. Again, the yellow here being the bulbocavernosus, bulbospongiosis, just at the superior aspect of the perineal body. So what are we going to do about this defect? We could take out our running interlocking and redo it, but that's less than ideal. So what we're going to do is to get a separate suture, and here I'm going to use, again, this 2.0 on the SH, which is smaller than what we would normally use as far as the needle, but I think a 2.0 vicryl would be fine here. And we're going to do an interrupted to get back and close the space. And depending on how deep this is, you might even have to loosen up a little bit of these what I try to do is to come in and throw this suture so that the needle is kind of parallel to the floor of the vagina. And what I'm trying to do is to come in and then out here. You can just see in the midline. And we're going to take this in 2 bites. You can do multiple of these even further back up towards the apex of the vaginal mucosa defect, but we're just going to do kind of one here just to demonstrate. So again, the needle itself kind of parallel to the floor of the vagina, and we're going to come in and kind of come out here. So now with this interrupted, and when we come to tie this, and we're just going to do a couple of quick throws here. It looks like that pulled through there. So now that we've thrown that suture, we've closed off this space here. So now we can come back up to our 3-0 and do our transition. So we transition from vaginal mucosa to perineal body. And then we're going to do our crown stitch. So we're going to really come up and get a good bite through that bulbospongiosus, bulbocavernosus. We're going to come out in the middle for that. So you can see where I came out on the bottom here, so I'm going to go in on the bottom. So this creates kind of a circle of closure. So you can see how that brings those 2 sides together. And now we'd be ready to transition to our perineal body closure. If this is a relatively shallow defect in the perineal body, I tend to do these in a kind of vertical mattress sort of way. So again, what I'm doing with the needle is that it's coming parallel to the skin edge and poking in a quick turn of the wrist. You can see that I've kind of backed up a bit or doubled up on this. When we think about doing subcuticular closures or subcutaneous closures, we usually come kind of straight across from where our suture came out. But sometimes when I'm doing something more for kind of bulking up, building up the perineal body, I'll backtrack a little bit so that I get a little bit of overlap there. And then we just continue to come down in this kind of vertical. And you don't want to get too close to the skin because then it'll pucker up, and we want to leave room for when we're coming back up for our kind of subcuticular closure, like that. So now let's back this out a bit. We're just going to end up kind of tearing these through. All right, so we did our transition, we did our crown stitch. But now let's say we've got a very deep defect in the perineal body. And if we come up here and do that horizontal mattress sort of closure, we're going to leave all of this space here uncovered. So in this case, what I do is to do, just switch to my smaller needle driver. I do a more vertical closure. So we go, now the needle is perpendicular to the skin edge. So we pop in here, come out down deep, and then match that up, go in deep, and come out kind of close to skin edge here. And I traveled quite a bit for that, but just to demonstrate how we decide to do either that horizontal or vertical. And again here, we go in, come out down deep. This one's a little bit angled. This is a little bit oblique. It's not perfectly vertical, but it's not horizontal either. So again, in, deep here, out, closer to skin edge, so that we're closing off the deep part. And then again, when we're ready, we would come and pop out just at the apex here. And then we're ready to transition to our subcuticular closure of perineal skin. And again, you can kind of swing around and forehand these, or you can backhand them. I do that both ways, just kind of depending on the anatomy. And again, here we would go in kind of straight across, or you can back it up, backtrack just a little bit. We're not quite as worried about little folds in the skin here. And then we're going to be ready for kind of our last little through and through. Since I came out here on the patient's left side, I'm just going to come across and kind of backhand this through for our little last through and through. And then we would tie that off.
All right, well, that brings us to the end of the videos. So, covered a lot of material. Talked about the different classifications of vaginal lacerations. We touched on vaginal and vulvar anatomy, suture selection for our repair, how to go about that stepwise approach. Again, for second degree at least, vaginal floor, transition, crown, perineal body, perineal skin. I hope that you found this helpful. A big thanks to Paul Schreck at the Sim Center for helping me to get the model set up and instrumentation for the repairs. We will be able to do our hands-on sim, I think, hitting the ground running a bit better for having watched this video, gone through the anatomy. I will be putting all of the individual videos of the chicken model closures on the channel as well, so you won't need to sit through the entire PowerPoint presentation if you just want to go back and reference some of those closures. I also have a couple of more videos that I did not include in today's talk, but I will include those as well. So, signing off. Thank you very much for your attention, and I will see you soon.